Hi, this is Group 19's post for their Google Hangout for Module 9. So today we're going to be discussing the issues of readmissions with heart failure. It's becoming a costly issue for the hospitals. So with the emergence, hold on, I need to introduce people. Okay, so my name is Sarah.
Hi, I'm Jennifer.
Hi, I'm Gracia.
Hi, I'm Valerie.
Okay. So with the emergence of new changes in the healthcare system, there are concerns regarding reimbursement for readmissions due to heart failure within 30 days. According to the Simpson article 2014 from the Journal of Nursing Care Quality, nationally the rate of unplanned hospital readmissions has been declining from 2008 to 2012. But it does continue to be more than 18%. Medicare's cost for readmissions is reported to be more than $17 billion a year, and healthcare costs associated with heart failure are expected to reach $45 billion by 2015. And this was all gathered from the Simpson article. So it's clear from this article that this is a big issue. And so today we're going to be talking about improvement in the quality report to help reduce these readmissions. So we're going to be talking about the different components of the report. So what we're going to be investigating, we first want to determine and identify who our at-risk patients are for readmission so we can target them with our interventions. So we're going to plan on investigating patient charts from 2011 to 2013. And this, the information that will be gathered from the charts will include the date of admission, the reason for their hospital admission, patient demographics, number of past hospitalizations, description of their social support system, date of discharge, and then if readmission does occur, the date of readmission. So, and then data that we should not include, so it's important to identify information that needs to be excluded from the reports, would be patients that died during their stay at the hospital, or patients that left against medical advice. So part of the identifying the data is identifying the patient population we're going to focus on. And according to the Medicare.gov website from the official U.S. government site of Medicare, they talk about part of the report is having a narrowed patient population. So we are going to identify a certain age range for the patients, and then also kind of base it on what kind of insurance they're on. Are they on Medicare, or are they on a private insurance plan? And so this information will be gathered to help target who our interventions are going to be on based on the data we collect from the charts, from the electronic health records. And so now Gracia is going to go in on different tools that we can use to help collect that data.
Yeah, so I just briefly wanted to add that, you know, in order to collect the information, and an important part of that whole information analysis and incorporates the patient safety organizations, the PSOs, you know, to help this hospital with the high readmissions rates and improve our performance. The PSO plays a very important part, like I said, in analyzing the data and in collecting the data and working with the different members of the healthcare team. And I did some research online, and I found a website from the healthcare, from the Agency for Healthcare Research and Quality. I found this website via the Agency for Healthcare Research and Quality Common Format Guide that was published in 2012. And the website is, once again, the Agency for Healthcare Research and Quality .gov, and it has a federally listed PSOs, so that's definitely one resource we can use to identify potential PSOs that will help us collect and analyze our information for this hospital.
And to kind of go off of Gracia, these PSOs need some kind of format, like she had mentioned, the common format. So the Agency for Healthcare Research and Quality from the 2012 user guide has designed a readmission common format, and it's based on information that is reasonably expected to be contained in a patient's medical record for their hospital stay. This common format will be completed either by individuals who are engaged in the readmission reduction program, the case managers, RN specialists, quality and safety staff, or even just by medical record personnel. These reports generated from the common format can be used by any hospital staff, physicians, nurses, or senior leaderships involved with the readmission reduction efforts.
Okay. And so part of the quality improvement report, we also need to list what our performance target is and what our goals are for reducing the readmission rates. And so we did some research, and also it was in the Simpson article from 2014 in the Journal of Nursing Care Quality. They talk about different interventions to help reduce readmissions, and it was targeted towards heart failure patients, which is what we're focusing on today. And so one of the factors that we're going to want to take into consideration is patient education. And they call it intensive patient education. And according to the Simpson article in 2014 from the Journal of Nursing Care Quality, higher rates of readmission are related to the inability of patients to manage their disease after discharge. So this provided us some evidence-based practice about how to reduce the readmission rate, so providing patient education. And with this, they found a 13% reduction in readmission rates. And so we're going to base for our performance target off of this article, since they were able to get a 13% reduction. That's also going to be our goal with our interventions, is to have a 13% reduction in readmission rates after we implement our interventions, which we will discuss later on. And so now we want to go into the actual process of how we're going to gather the information. And so Valerie is going to start off, I believe, and talk to us about how we want to gather the information.
Right. And how the information can be included in the hospital systems. So I looked at the article in Gallagher and Roll, 2003 Nursing Administration Quarterly, and the authors report on nursing sensitive quality indicators. And those indicators help shape the future of this profession. So the article focuses on factors by the American Nurses Association that are used to develop these indicators, and that was really the birth of the National Database for Nursing Quality Indicators, or the NDNQI. So the process for gathering information, which we are going to be using in our project, is number one, the American Nursing Association formed the Nursing Patient Safety and Quality Initiative to help with public accountability. So they looked at first, it's called the Nursing Care Report Card for acute care. That gives information on the length of stay, pneumonia, postoperative infections, pressure ulcers, and UTIs. So it helped identify nursing any sensitive indicators. And these indicators are easy to follow and really believed to be a reflection of the nursing quality. Number two, along with the formation of the NDNQI, and that's really just a database designed to be, it involves all the indicators, but comes policies on the confidentiality and transfer of patient information. So each facility has its own identification number, and that number is really only known by a few staff members, and that's supposed to help with the confidentiality or leak of information. The third would be a Medicare beneficiary data, and that's suggested for use in any data set, so that would include in-hospital and discharged patient deaths. So nurse administrators must ensure patient care by considering patient and staff variables. So their safe patient care is documented in the nursing quality indicators and throughout association with this NDNQI. So by looking, to make it simple, by looking at this information, the administrator can really initiate steps for improvement, and the administrators can view a successful unit and implement or initiate similar work strategies in a unit that needs help so they can bring it up to par. And this can be achieved through seminars or various teaching methods. So, and then the fourth would be continuous learning to help a unit improve its patient care delivery and make it possible to obtain new successful methods that are evidence-based. Another outside article I found, there's no author, but it's from 2004, the MedPAC.gov Congressional Reports, Chapter 7, titled Information Technology in Healthcare. And that talks about how different care facilities are adopting or kind of putting up a barrier against IT. So they try to promote it from within the healthcare settings. And the author proposes financial incentives which would help standardize the record formats, nomenclature, and communication protocols to enhance interoperability. So diffusion of information is really the mostly administrative and in the financial areas. That's what they're finding today. Next, the clinical uses for order entry for drugs, lab work use, and electronic medical records. So the financial return on the investments really are driven or trying to get people to accept new IT purchases. So by improving patient outcomes, it's expected really with any of these improvements. So the interesting thing, the article also did state that physicians use IT more for administrative purposes, which would be billing, making appointments, lab orders, etc., rather than for clinical use. So clearly the physicians have to be educated on the revenue return, the time saved, and such. The last part that I wanted to comment on was how we would incorporate this information into our hospital system. So we could use the following. There's a CBR, which is called Real-Time Case-Based Reasoning Technology, and it's technology that's being developed by Verdande Technology in conjunction with the Methodist Hospital System too, and that evaluates the risk and the use of evidence-based decisions on past events which would help with current patient care. So it really is just like a constant a piece of technology. The physician would walk around, he'd enter in everything else would be there. It'd be less time consuming, and it would improve really the client outcomes. So as soon as we get the results from that, if it's profitable and if it works, then we'll bring that into our system. Another is eliminating barriers. I touched on that before. You need to acquire certain skills to use these systems. And really the physicians with the current systems don't want to give up that revenue-producing time away from seeing patients to learn these new systems. So MedPAC states that the cost of the system really has been shown to increase volume in nonprofit hospitals, but we have to educate the doctors. The third is making sure that the system follows HIPAA guidelines. And I think, Sarah, you were going to touch on that regarding confidentiality.
Yeah. I just wanted to pull in from the Peterson, DeMuro, Goodman, and Kaplan article from 2013 in the Journal of the American Medical Informatics Association. They talked about a case. It was Sorrell versus IMS Health, and they talked about the issues of collecting large amount of data, which you're talking about, Valerie, and compiling all this data. There's a lot of issues with patient privacy, which goes along with HIPAA. And so I feel like we can look to this case as a guideline to make sure we are following the law in terms of collecting this data and making sure that we're keeping patient privacy as an important part of our data collection. And Jen, I believe, had something to add that was more specific onto how we can keep the patient information private.
Right. So from that same article, Sarah, the Peterson, DeMuro, Goodman, and Kaplan from the 2013 Journal of American Medicine, Information Associates state that in order to protect personally identifiable patient information in compliance with HIPAA, as well as to allay those patient concerns, informaticians must continue working to develop a more robust way to prevent inappropriate data re-identification. So I think that incorporating those informaticians, more into this plan is going to be very critical. They're going to be the ones that are going to have to keep the HIPAA regulations up to date and make sure that all the systems are everyone's in compliance with that. So with this implementation, health information exchanges the opportunities to use patient health information for patient-focused purposes, such as outcome researches and quality improvement, like what we're doing here today, and this will grow substantially. And this is basically from the, that article, and that's, informaticians are going to be a very, critical role in keeping that HIPAA compliance.
Okay, so getting back to the how to incorporate information into the hospital system, I just have a couple of more suggestions. The other is we're doing research to secure the appropriate application, and that involves cost, making sure it's user-friendly so the physicians would actually not hesitate to use this and realize the benefits. And then meet the requirements of the hospital, the administrative requirements, as well as the clinical requirements, and that's amongst the various units. The fifth would be funding possibilities, and that's also discussed in medpac.gov. The cost is really a barrier for a lot of these organizations because obviously money is not what it used to be. So there are government and local health authorities that might cover some of the technology or the cost, but they just wouldn't pay for the training. So individual hospital responsibility, and they're actually doing a study on this in England where a national program is being implemented. It's called the Healthcare Initiative for IT Systems. And we have the Markle Foundation here and the Santa Barbara Community Grants, which offer money to hospitals trying to help or gather more acceptance of these programs. The sixth one, we're talking about looking at analyzing each unit. If there is a unit that's successful using their IT system, we'll implement that and to another unit that might not be incorporating and having lower level of outcomes. And then the seventh, is information from the Affordable Care Act, the ACA, and the Patient Safety Organization, or PSOs, can be used to help hospitals reduce the high number of readmissions. And that's all stated in the user's guide, common format readmissions version 0.1 beta. And that really just talks about the forms, the methods to facilitate, making sure it's navigable by healthcare weapons. And I think we're going to go off on that, correct?
Mm-hmm.
Okay.
So once this information is gathered, the data will be interpreted to determine the best methods for improving quality.
Okay.
Mm-hmm. Okay.
All right. And so once we've analyzed and interpreted the information, we're going to talk about the different strategies we can do to actually help reduce the readmissions. So we're going to talk about specific details on what we could implement into our hospital. So I'm going to pull from the Simpson article again from 2014 from the Journal of Nursing Care Quality. And I had discussed earlier about the intensive patient education. And so this would specifically emphasize the importance of medication maintenance, taking your daily weights, different dietary restrictions, and symptoms that should be reported to their provider immediately. So if patients are given this education and given this information throughout their hospital stay, hopefully we will see improvements in the readmission rate. And there's some other interventions we're going to talk about. I think Gracia had something else to add to that.
Yeah, I was, so since we're talking about the increased readmissions, I was doing research on different strategies that different hospitals have implemented. In particular, I found this article by the American Journal of Medical Quality. It was published in 2013 by Ahmad, Matley, Barg, Henderson, and Werner, who conducted a qualitative study to identify the different strategies being implemented in the different hospitals to reduce readmissions. One of the strategies among the many that they found specifically was to refine the electronic health records based strategies, to improve those transitions. So refine the electronic health record to improve care transitions. There were several institutions that led improvements for the electronic health record system, specifically that focus on the communications of discharge summaries to the PCPs, to help with the care transitions. In another institution that these team of researchers found was another institution was looking at the health electronic records. They focused on improving the format and on the content of the discharge summary, specifically by including information about medication reconciliation, diet and activities, and then in another hospital, they focused specifically on the design that facilitates sending the records, the patient's medical record, to PCPs. And so specifically, just the researchers, made these suggestions to really take these findings and to really try to implement the easy-to-read summaries for patients and more readable communications between the hospital, the team of hospital physicians, and to the outpatient and the PCPs, the primary health care physicians. And I think that's really important because a patient who is admitted at the hospital who doesn't follow up with the PCP, the chances for them to be readmitted could be very high. Specifically, I think those interventions on improving the electronic health record are really important to facilitate those care transitions, and in the end, to reduce the number of heart failure readmissions.
Okay. And then Jen, I think, did you want us to add anything else for that?
Yeah, and actually I have some recommendations, kind of just to go off of Gracia. I think we also need to get the staff involved as well with the nurses. And I found an article from Desai and Anderson. It's from the 2014 American Heart Association journal. They state that readmission rates are higher when psychosocial and socioeconomic factors limit adherence and compliance with medications, self-monitoring, and follow-up. And I think in order to overcome this lack of adherence and compliance, social services should be implemented in the plan of care immediately by the nursing staff, especially if the patient does not have a caregiver or somebody outside of the hospital to help them. Again, from the same article, Desai and Anderson from the 2014 American Heart Association, they also state that comprehensive discharge planning, including patient and caregiver education, guidance regarding sodium and fluid restriction, collaboration with visiting nurses, and planned follow-up may reduce early readmission rates by as much as 25%. And again, so patient education is going to be a key factor in reducing these rates. Educating patients on the importance of diet and medication regimens should be implemented by the nursing staff immediately upon admission, just right when the patient arrives. So that way, goals can be established early on, and we can detect whether or not any barriers that may keep these patients from attaining a healthy regimen. So I think those are also important to incorporate for interventions, or recommendations for this.
Yeah, I think so. Overall, I think we should recommend for the hospital to starting with intensive education, bringing in the social services, talking about improving communication among the healthcare team, and all of those should help reduce the rate of readmissions. And so I think that's a good place for us to start for implementation.
Right, and then just really briefly to mention, I noticed that when I was reading the 2013 Peterson article, I felt like I highlighted some important points on patient-provider relationship. I know Peters and colleagues discussed the importance of ensuring confidentiality of their prescription drug records by their providers. And Peterson mentioned that the lack of confidentiality can prevent patients from receiving appropriate and effective health care. As patients might not tell providers the details about their health and any concerns they might have if they feel like they can't really trust their providers, or that there's a lack of confidentiality. So, I believe that that's a really also an important component to implementing an effective electronic health record system. So, to pay special attention on the technology design and the product development, that will protect patient information, especially from outside sources and marketing companies. So, just wanted to bring that up really quick.
And that kind of ties back to the communication aspect as well that we talked about as our interventions. Having the patient cooperate with giving us accurate information is important to have reliable data for us to base our interventions off of.
Right.
So, all right. And Valerie, did you want to wrap us up?
Yeah, just to describe what we've learned or our takeaways from these activities. I think what's most important is, depending on, we look at all of this research, all the information, and we evaluate the outcomes. And from those outcomes, we'll implement a system that works for us that could be really made hospital-wide. Another is the education in different units. It seems like each unit works independently. And I think, getting everybody on board, the physicians, the nurses, the PCTs, the pharmacy lab, everybody needs to be educated so that they can truly realize the benefit of having a good IT system, or just information all coming together. One of the most important things, though, that came out of this is confidentiality, because that, as Gracia was just saying, that does affect healthcare for the patient, as far as how much information they're telling the physician. If they're worried it might be leaked to an employer or to an insurance company. So that's something, we're always taught about HIPAA, but confidentiality is something that everybody in that healthcare facility needs to be concerned with. And I think that's how I'm going to end, because it was a good learning experience for us, and this is what we're proposing as the board. Okay.
All right. Thank you guys for your time.
Thank you.
Thank you.
Right.
Bye.